Facade Specialist Hospital called Bar in 2004. As an outpatient nurse, she climbed up the rank very quickly to a nurse manager in 2005. She moved to King Fahd Specialist Hospital in Dubai in 2009 as an oncology nurse and was promoted as a clinical nurse coordinator that year. Anne is a certified biotherapy and chemotherapy provider by the Oncology Nursing Society of America. Her clinical interests include multiple myeloma and HSCT. She has been active in various research and is a member of several organizations, including Saudi Society of Blood and Marrow Transplant, Eastern Mediterranean Blood and Marrow Transplant, and European Group for Blood and Marrow Transplantation. I'm very pleased to introduce Anna, and she will be talking today demand experience on outpatient autologous HSCT with multiple myeloma patients. Thank you so much.
Thank you so much for the pleasant introduction, Angela. Good morning.
Good morning.
Everybody's alive and awake, still in the morning. Well, just a little, to wake you up a little. On this side, please look on the partner on your left. Yeah, on your left. And on the right, please look on the person at your right. Look them in their eyes and say, "You're doing a great job. Happy Nurses Day." For the doctors, thank you so much for the support. You are the winning doctors.
Happy Nurses Day.
So, is everybody awake? Happy Nurses Day?
Yeah, Happy Nurses Day.
Happy Nurses Day.
You know why we are celebrating Nurses Day?
Yes, because we're special.
Of course. We are and we do. And to give honor to the founder of the modern nursing, who is?
Florence
That's
Nightingale.
not my topic. I'm just giving you a segue to uplift your mood a little bit. Okay, so yesterday was her birthday, Florence Nightingale, the founder of modern nursing. That was, yesterday was the nursing day, but still, it's a nursing week. So welcome to National Guard. And now I will speak about our topic, from the mom, fresh from the mom. We will share, by the way, thank you, Saudi Society, for inviting us to share our experience. We are very eager to share our experience about autologous transplant. So what's so special about autologous transplant, multiple myeloma? We're also doing that here. Yes, you're doing that here, but we are doing it in an outpatient setting. Are you also doing that in the outpatient? So that is our edge. A little, but I know in few months' time, you will also follow our steps. Okay, so since 2010 till 2017, we have a total cases of 206 for adult only. This is an adult statistics only. And in autologous, we love so much multiple myeloma, which is my field of love. So with multiple myeloma, we have a total of 75 cases. When we started in 2010, we started it as an inpatient, just like the rest of the hospital in the kingdom. So we admit the patient on day 1 with a mobilization until we start the GCSF on day 4. We collect, still admitted, we infuse, of course admitted, and until the engraftment. Everything is admitted. But then, you know our current status, we don't have much budget, we have long waiting queue for transplant. You know that our hospital only have 14 beds for hematology and only 2 beds dedicated for transplant. And how are we going to manage with this number of patients? So, we decided we will follow what is being done already in Europe and in the Americas. Since as early as 2006, they're already doing this transplant in an outpatient setting. So now that our supply of supportive care is available and the conditioning regimen that will be given is a melphalan, can be given as outpatient, so why not? Let's give it a try. So, what will the hospital benefit from this? For the patient itself, they will have a shorter stay in the hospital. And you know later on what is the benefit of staying in the hospital in a shorter period. Definitely, the patient will avoid nosocomial infection. And lastly, cost effectiveness. Although we both know, here, do patient pay? No. Same with us, but there is another population with our patient that they pay. So, you consider it as cost-effective. So the aim of this program, as we enter this study, is to evaluate the feasibilities and toxicities of a patient having an outpatient basis hematopoietic stem cell transplant. But out of that 75, we cannot put all of them in this program. We have to have this eligibility criteria. Number 1, psychosocial evaluation. Do we have a good family support system? Family is number 1 in this. The patient will have a full accountability of their health. Do you agree on that? Will I ask you, did you experience with your patient, Mama, had a shrub had dexamethasone? What will the mama say?
Naam.
Dexamethasone. Listen it, like, they are not really that much keen. They are not that much keen. But with this, we have to push them to be accountable to their health. Secondly, is patient compliance, as I said. A lot of our patients cannot even follow our reminder to them. Take this hubub twice a day, take tarwish, take a shower, change your clothes. Unfortunately, some of them doesn't abide on that. So we should assess the compliance of a patient. Number 3, caregiver. 24/7 caregiver. Why? Because the nurses are not around as an outpatient to be a 24/7 caregiver. So they need a family member to do that for them. And of course, they agree on all of this. So, the design of this study, the patient, from the mobilization, to the collection, to the infusion, and until the recovery, as much as possible, will be in an outpatient setting. Okay? So, until the infusion, we don't admit them as much as we can. They will fall onto this study. Antimicrobial, antifungal, antiviral, prophylaxis medication are started on day -2 of the conditioning regimen, and multiple myeloma is melphalan 200 mg per meter squared unless the clinical situation of the patient will only allow him with 140, like with the renal concerns or something. G-CSF filgrastim, 5 microgram per kilogram, will be started on day +5 unless it will be deemed necessary by the physician that it has to be started earlier. And patients will be coming to the outpatient clinic on a daily basis or every other day, depending again on the status of the patient. Now, I know if you are reading together as I talk now with the book, you will see that I wrote in the abstract 15 patients. Yes, that's true. But the organizing team asked me that 4 weeks ago. And I'm giving you an updated number of patients. In less than 10 months, we have done 19 cases as outpatient. 13 of them are the first transplant, and the other 6 are second transplant, or the tandem. 10 are males, 3 females, median age of 52, we have as young as 35, as old as 65. Now, do they ever get admitted? Yes, they do. If the need arises, we will admit them for the following reason. Number 1, if the patient have a fever more than 38 and above, of course, why will we keep them on the clinic? They definitely have to go for inpatient. If they have nausea and vomiting persistently, mucositis that would require them total parenteral nutrition. And of course, a toxicity of more than grade 3. Alhamdulillah, none of them have already encountered this one. Now, our recovery period for the patients, their neutrophils, median day for us is 11 days. The platelet, median days as well, is day 11. They are already in grafting. But if you will notice, for the admission, out of these 19 cases of transplant, we admitted 10 patients. 3 of them because of mucositis. You know how melphalan is to our patients. So, better remember what preventive measure the nurses are doing before giving melphalan.
Cryotherapy. Ice
Ice chips, cryotherapy. And 7 out of the 10 admissions develop febrile neutropenia with nausea. So, total hospitalization out of these 10 patients is only 42 days. How many days do you admit a patient for autologous transplant? 3 weeks? 4 weeks? Depending the most. This month, cumulative, 42 days only, with a median day of 3 days as they stay in the hospital. So as I mentioned earlier, there is no grade 3 toxicity developed with our population. This is a question, what is the greatest challenge for the nurse? Hello? I still have it, yeah. What is the greatest challenge for the nurse for an outpatient transplant? Of course, infection control is number 1. Our patient doesn't die because of the disease at that time or because of the transplant per se. It's more of controlling the infection. So, first thing, central venous catheter maintenance. With our practice in King Fahad, we will only insert the central venous catheter a day before or on the day of the collection. Internal jugular line, and that will be used for the collection if it will be day 1, day 2, day 3. Sometimes, multiple myeloma, we need a day or 2 to collect them. And the same line will be used for the melphalan, and the same line will be used for the stem cell infusion before we pull it out. So, remember, these patients are going home. So, we have to ensure these are now the job of the nurses in the treatment area or in the C5 short stay. They keep on assessing the site, securing the site, reminding the patient and family, please keep it safe. Next is patient hygiene. Of course, when the patient is inside the unit, you can push them, you can always be there. Now, of course, as a nurse, you should have some sort of initiative or some sort of way to convince your patient. Alhamdulillah, because of compliance issue, they do follow. When we advise them daily showers, daily changing of clothes, when they come into our unit, they are all dressed up, nice and clean. Next is accommodation. Remember, in the hospital, your patients are isolated. So what about this patient? See, before the transplant, during the pre-BMT period, we are already assessing and orienting the patient. If you will fall in an outpatient transplant, you should have a dedicated room in your house, free of curtains or carpets, or you will not be allowed to clean, so on and so forth. But as long as the house of the patient is within 30 minutes radius away from the hospital, we will allow them to go home. If that is farther than that, our hospital will offer a flat inside the compound. So they are outside the hospital per se, but inside the hospital compound, wherein it's a walking distance only. Our housing, of course, has been checked by our infection control, terminal clean by our housekeeping department to ensure that it is free of, fungus and molds, so on and so forth. Dietary restriction. Actually, this is a #1 concern with patients who are allowed to go out. Why? Even though you tell them, please do not eat in the restaurant, please do not eat your favorite shawarma. They come in complaining of abdominal pain. First question, what did you eat last time? I went to restaurant. So, this is the challenge with them. Even educated patients do commit this mistake. For our patient, we supply them food from our cafeteria with proper label, if it is a neutropenic diet or anti-emetic diet. So the challenge here is, for the nurse again, don't ever get tired of reminding your patient, okay? And lastly, social limitation. Even though the patient will go home to their families, they are still not allowed to hug and kiss their small bundle of bacteria. The kids, you know them, they are factories. So, give your health education very clear, okay? You are allowed to go home, but no hugging, no kissing with the kids, no visitors as much as possible, no flowers as much as possible. There's no pets in here, so for sure there's no pets. In the housing, they are only allowed with one caregiver at a time. And of course, the kids are not also allowed to get into our accommodation. That's it for the nursing challenges. Conclusion. So we found out that with these 10 months that we are doing our autologous transplant in an outpatient setting, it's not only cost effective, we also find it very feasible and safe for our patient. Why? It offers lower risk of infection for our patient. It decreases the waiting time. We don't need to fall in queue for a room in our hematology BMT ward. It also increased the bed capacity for our allogenic patients. Significant cost saving, as I mentioned earlier. And last but not the least, somehow, the quality of life of the patient is still there. We improve patient satisfaction as we don't deprive them to be shut out of the outside world. So, just an acknowledgement for this study that we have conducted. And, as I said, as a nurse, I always do appreciate the doctors. Although we are nurses, the unsung heroes, without our partners in crime, we will not be able to do what we do best, isn't it? So, my boss, Dr. Hali Al-Hashmi, the Director of Oncology in King Pahagamang, the Chairman of Hematology, which is Dr. Khalid Alanes, and our two Greeks and handsome doctors, Dr. Panayotis and Apostolidis, they are a transplanter, all around hematology, lymphoma doctors, so and so. By the way, all of them are transplanters. Oh, it's not yet done. I would like to take this, I still have time, I would like to take this opportunity to acknowledge the outpatient nurses who is handling the patient in the outpatient setting. Oh, by the way, this is our humble office. This is me. This is Ashraf, the allogenic coordinator. And that is Jennifer, the one in charge of the lymphoma. So we have a small strip only, and all the patients fall into in here. This is our nurses in the clinic. So what happened is hematology, from the induction, they will arrange for the chemotherapy, isn't it? After 4 cycles, they will be evaluated. But during the chemotherapy arrangement, they will be endorsed to another outpatient unit, hematology treatment room, and Fatel now will give the chemotherapy. After 4 weeks, after 4 cycle, if they pass, they will be forwarded to the BMT nurse RIM, to the BMT clinic, to work with us. When RIM is finished, forwarded to the coordinator, we personally even hand over to the C5 nurses the patient. The coordinator in PAHAD is all around. We are porter, messenger, name it, we are doing it. So these are the C5 short stay nurses. This is our day case unit. So patient will come 7:30 in the morning, 5 o'clock. If they are finished, salama. Come back again, Baba, tomorrow for your hydration. Like that. So, Jomar, Alani, Delia, Elmi, and their managers and team leader. So, just to show how happy we are in our team. This is not every day, there is just a birthday last time. So, our doctor is having a birthday cake it's a birthday of Olivia at that time, one of our nurses. And this is the C5 short stay with Dr. Han. They are the serious one. They're not eating there because they're a little busy. They have a 5-bed capacity room. They can accommodate 5 patients at a time. Some patients will only require 3 hours hydration or so they can go home. And lastly, as a take-home message to everyone, as long as you can do all of this, you listen, you understand, you counsel, you touch the hand of your patient, sometimes they will allow to hug you, or sometimes they are hugging you, without a prescription or without advice from everyone, then you are a super nurse. That's all. Thank you.